Good day. It's a great pleasure and honor for me to present this paper on contrast-enhanced ultrasound for pancreas imaging. So basically, when using ultrasound for pancreas imaging, we can either use transabdominal ultrasound or endoscopic ultrasound, and both techniques have the possibility to use either high mechanical index or low mechanical index. When talking about contrast agent harmonics, they are generating by nonlinear resonance. Usually the transmitter, the transducer, emits with one frequency, and then both the fundamental frequency and the second harmonic are received. And when doing contrast harmonics, different types of techniques are used. One example is low mechanical index pulse inversion harmonics, where the tissue response is diminished and we get only the agent response, the second harmonic, by summing the components generated by the microbubbles when they are resonating during ultrasound examinations. So basically this is how it works. So the fundamental grayscale image is on the right side. When using a special technique called wideband pulse inversion, only the signal from the microbubbles is amplified. So we get rid of the tissue signal and we can examine only the signal induced by the microbubbles. So then the ultrasound contrast agent that we are using is SonoView. This is a blood pool ultrasound contrast agent which is injected through an antecubital beam, and then it goes through the vessels. It doesn't get out from the vessels, it stays in the vessel, and in this way we can obtain enhanced images of the macro and microvasculature. And this is an example. So the advantages of the low mechanical index techniques is there are no artifacts, no flush or overpainting artifacts. The resolution is impressive. So you see here a tumor mass on the pancreatic body, and you see the splenic artery, which was completely encased by tumor tissue. And in this way, we get information on diagnosis, staging, but also information useful for therapy. So basically there are two types of examination: a high mechanical index, where color Doppler or power Doppler is enhanced by the use of contrast agents, and the low mechanical index, and I explained the pulse inversion techniques, where we get rid of the tissue signal and we obtain only the signal induced by the microbubbles in the circulation. There are two techniques. So one is transabdominal, so contrast enhanced transabdominal ultrasound. The other one is endoscopic, and I will go briefly through each one of them. So contrast enhanced ultrasound is indicated for lesion characterization for previously detected pancreatic lesions. So it's not useful for detection, it's useful for characterization. And it takes into account the pancreatic blood supply, which is entirely arterial. And because of that, we have only two phases, so it's different than the liver examinations. We have two phases: an early arterial phase, which lasts up to 30 seconds, and the late venous phase, which lasts up to 2 minutes. And then in a CU study, we look at the pancreas. We can usually compare the focal mass with the surrounding pancreatic parenchyma, but also the relationship with the peripancreatic veins and arteries. And we can also examine the liver in the late phase for identification of possible liver metastases. These are a few examples. So this is an example of a chronic pseudotumoral pancreatitis. So we're looking here on the pancreatic head. So we inject contrast, we wait for the arterial phase. Now you see the microbubbles coming, and you see that the whole pancreatic head is hypervascular. This is usually dependent on the degree of fibrosis, and there's a small pseudocyst as well. And you see here the duodenal wall, which is a bit thickened due to the surrounding pancreatic chronic pancreatitis. This is another example. So we inject contrast and we wait for the microbubbles to show up in the arterial phase. And now you see this enhancement. You immediately see that there are cystic spaces. So actually this was a pseudocyst or an acute fluid collection, more exactly, which was surrounding the duodenum. And the patient had, again, a chronic pseudotumoral pancreatitis, and he came with gastric outlet obstruction. So what you see here is the duodenum actually surrounded by the acute fluid collection. Then if you look at the pancreatic adenocarcinoma, you see here a nice image with the left liver lobe, the gallbladder, and then a hypoechoic tumor mass at the level of the pancreatic head. And then we inject contrast, and you'll see the contrast showing up in the hepatic artery initially. But what you see is that the tumor mass on the pancreatic head is hypoenhanced in all phases. And the size and the margins are better detected by CUS, and the relationship with peripancreatic arteries and veins is clear. So this mass is hypoechoic in the arterial phase, but also hypoechoic in the late venous phase. Then in neuroendocrine carcinoma, this is a mass at the level of the pancreatic head. And again, you inject contrast, you wait for 10-15 seconds, and you will see the contrast showing up. You will immediately notice that the mass was hyper-enhanced. So this was a hypervascular mass with a necrotic center. And the patient, and this mass in the arterial phase, this hyper-enhancement in the arterial phase was washing out in the venous phase. And you see here a liver metastasis. So a hypervascular liver metastasis. So the same patient had a hypervascular liver met. When looking at the pancreatic pseudocyst, again, it's important to look at the wall, and the wall is usually unenhanced because it's a fibrotic wall. But then if you look at this image, this was a patient with a suspicion of a tumor mass on CT. You inject contrast, and then you see that the whole lesion is completely non-enhanced. So this was actually a pseudocyst with debris inside. So there are two applications for contrast in the diagnosis of cystic focal masses. So the first application is differentiation in between pancreatic pseudocysts, which have a non-enhanced wall, and cystic neoplastic lesions, which have a wall that enhances. And the second application is differentiation of debris and solid neural nodules. If you look at this cystic mass, this was a huge cystic mass occupying the epigastric region. You can see that the whole pancreas was flattened behind this lesion. And if you look with contrast, if you look at the wall, so you inject contrast, you wait for 10-15 seconds, and then you look at the wall of the lesion, and you will see that the wall is hyper-enhanced. So now you see that microbubbles are coming up. You see the wall is hyper-enhanced. And this was an IPMN. And we did an US guided FNA with a large 19-gauge needle, and we took out mucin. So this was a very large IPMN, main duct IPMN. Then when looking at contrast-enhanced endoscopic ultrasound, there are applications here as well. The advantage as compared to transabdominal is that the transducer, it's a small part transducer, a linear transducer, so the frequency is higher. So then you get a better resolution, but a smaller penetration as compared with transabdominal probe. This is how it works with contrast. So you can use Doppler or Powell Doppler, so high mechanical index technique. You inject contrast, you wait for the contrast to show up, and this is a hyper-enhanced mass. This was a hypo-enhanced mass. First one was chronic pancreatitis. The right side image was pancreatic adenocarcinoma. And this is how it works in a high mechanical index mode. So basically you have Doppler, a focal mass at the level of the pancreatic head, and with Doppler we inject a very small quantity of sonoview, of contrast, and then we look at the vascular signal, and you will see that after 15 seconds the vascular signal is quite enhanced. So this was contrast enhanced power Doppler, and basically this was a hypervascular or pseudotumoral chronic pancreatitis. This is another example, a hypoechoic mass. This time again sonoview was injected, and then we have to wait for 10-15 seconds, and you see that the signal is surrounding the tumor. So basically this was a pancreatic adenocarcinoma. So it's a hypoenhanced mass with some collateral circulation. This is typical for pancreatic adenocarcinoma. You can also combine contrast enhanced Doppler with real-time sonarelastography, and in this approach we found an accuracy of over 95% for diagnosis of adenocarcinoma. And please don't forget that there are other focal masses. This was an example of focal pancreatic ocular melanoma metastasis. You can see here the collateral circulation, and this was confirmed after USFNA puncture, and you see that it was positive for HMB45. Other focal masses, this is an example of a neuroendocrine tumor. So basically before contrast enhancement you see some Doppler signals. After contrast enhancement you see that the mass was actually hyper-enhanced, and you see here the hyper-enhanced or hypervascular neuroendocrine tumor. Again, diagnosis confirmed by USFNA. This is a rare tumor, so it resembles a serous adenoma with a multiple cystic spaces, but actually it was 4 lesions like this, and then the lesions were hyper-enhanced, and when we did final aspiration, then the diagnosis was of pancreatic lymphoma, and it completely disappeared with chemotherapy. Then low mechanical index show up on the market, and we usually do 1 complete vial of sonoview with a mechanical index of 0.2, and these are a few examples. So basically this is a chronic pseudotumoral pancreatitis, hyper-enhanced pancreatic head. So again we inject contrast and then we wait for the contrast to show up, and then you see 2 small cystic masses, but basically the pancreatic head was pseudotumoral, but it's hyper-enhanced. It's not hypo-enhanced like pancreatic adenocarcinoma, it's hyper-enhanced. Then in chronic pancreatitis, then you can also use it for differential diagnosis of pseudocysts. This is an example, and the patient also had a chronic infarction. So you can use this kind of contrast examination to diagnose the complications of chronic pancreatitis. And pancreatic adenocarcinoma is hypo-enhanced, so over 90-95% of them are hypo-enhanced. There are some tiny vessels inside which usually indicate poor differentiation, but basically the tumor is always hypo-enhanced or hypovascular as compared to the surrounding pancreatic parenchyma. What we can do further is to quantify, so we can use time intensity curve analysis. So this is an example of a pancreatic head mass in the early arterial phase and in the late venous phase. And you see how it looks, and you see the time intensity curves. So in yellow is the normal pancreatic parenchyma, in red is the tumor mass which was hypoenhanced. This is an example of a hyperenhanced pancreatic neuroendocrine carcinoma. So in inject contrast, you see that the mass was hyperenhanced, and you can see the same appearance on the time intensity curve. So basically in red is the tumor, which is hyper enhanced, and in yellow is the normal pancreatic parenchyma. We can also use contrast enhanced endoscopic ultrasound to target therapy. So in this example, you see that the liver is inhomogeneous, but you don't actually see clearly what's happening there. So then we injected contrast, and you can see here there were multiple liver metastases, one here, one here, one here, one here, and we punctured the metastases with a 22 gauge diagnostic needle. So the advantage of contrast-enhanced endoscopic ultrasound is better staging, and you will see here the contrast coming through the celiac trunk, and there is encasement of the origin of the celiac trunk. You see here the splenic artery and the hepatic artery, which was completely embedded. So this is an example of usage of contrast-enhanced ultrasound for accurate staging, because you see a rim of tumor tissue on the other side. So basically the whole confluence where there is this small stenosis, the whole confluence was encased by this large tumor. We also did a multicentric trial. We used time intensity curve analysis on 167 patients, and we got a sensitivity of 87.5% and the specificity of 92.7%. So pretty good numbers. If you look at the meta-analysis in the literature, this is an older one, but there is another one which is more recent. So 12 studies, pool sensitivity is 94%, pool specificity is 89%. Then a few words about three-dimensional endoscopic ultrasound. There are some advantages for the location of tumors and relationship with the neighboring organs and vessels. So with improved staging and the resecability, and the images are comparable with CT and MR, so they are reproducible. So you see an example here. So we used power Doppler with contrast enhancement, so injected contrast, and you see here the tumor mass and the collateral circulation and also the splenomesenteric confluence. So basically you can take a look at the relationship between the tumor and the splenomesenteric confluence. So this is how it works. It works with manual acquisition. These are some examples from the literature. But basically with the endoscope, we just turn the endoscope 180 degrees. And this is an example of a tumor encasing completely the celiac trunk. And you see how the 3D reconstruction worked. However, we will still need final aspiration or final biopsy, as tissue is the issue, especially for oncologists. And one way in maybe postponing or getting quicker the result of the biopsy is the confocal laser endomicroscopy. It's a fiber fitted into a 19 gauge needle with a resolution of 3.5 microns. But if you look at the resolution of images, this is pretty good. And you see the terminal ileum, so the microvilli from terminal ileum. You can actually see with the same probe the erythrocytes flowing through a capillary. In our initial experience, US-guided needle-based confocal laser endomicroscopy had a very low inter- and intra-observer agreement. And we think that other future techniques are really interesting. So one of them is fusion imaging. This is a technique which merges real-time ultrasound with previously acquired CT or MR or PET or even another examination with ultrasound. And there is a possibility to use body motion and needle tracking for fast synchronization and tracking of the needle tip. Then EFIL simulator can offer a color map simulation of the electric field during radiofrequency ablation. This is how it works. So the CT cube is uploaded into the ultrasound system, and then an auto registration can be done, and you see the tumor here on the left side, the tumor on the right side. And the same thing is with this small hemangioma. So you see the hemangioma on CT here, hemangioma on ultrasound right here. There are advantages of this technique. So basically it merges real-time ultrasound with previously acquired CT, MR, or ultrasound images. There is the possibility of direct comparison of the lesions, and it can be used through the disease cycle. So we can do an ultrasound now and an ultrasound after chemotherapy or other radiofrequency ablation, and you can fuse both of them. And then there is a 3D SIM navigator, which allows a precise needle placement even by non-expert users, especially in fusion imaging mode, and you can get positional relationship of multiple needles for radiofrequency ablation with this kind of system. The e-field simulator, it simulates a distribution of electric field during RFA, and what we do need is innovations in real-time RFA needle guidance to improve the complication rate of the patients. There is a possibility of magnetic navigation needle tracking and also auto-correlation, because this kind of active patient tracker can be used for automatic registration of fused images in the moment that they are done in the CT or MR. Then this is an example of locally advanced carcinoma, and the image on the left is CT, and the image on the right is is ultrasound. So even if you don't have a good ultrasound image, you will have the CT image, and they are co-registered, so they move in the same time, both of them. Of course, the idea would be to do radiofrequency ablation, and you can see how the needle goes into the lesion. However, radiofrequency ablation is used for palliation. So incomplete ablation is always planned. Then you can use e-field simulator to estimate the area of ablation. And then if you use needle tracking, that indicates the needle position. Thank you very much. And I'm open for questions.